Good afternoon. This is Kelly Pfeiffer at the California Healthcare Foundation, and I welcome you to our webinar on CURES. We're going to give people a few more minutes to log in, and then we'll get started. Good afternoon. This is Kelly Pfeiffer. We're going to give one more minute for people to log in as we see some attendees trickle in, and then we'll get started on our presentation. Hello, this is Kelly Pfeiffer with the California Healthcare Foundation. Thank you so much for joining us today. We have a great presentation for you just in time for the deadline to register for CURES. We had heard from many people that there was interest in not just what CURES has to offer, but how it's practical, both in the busy setting of an emergency department and in the primary care office. So we've got a great group of speakers for you today, and, and we'll go ahead and get started. So Robert, if you could advance to the next slide. This presentation is part of our Opioid Safety Coalitions Network. California Healthcare Foundation is supporting coalitions across the state to work on safer prescribing practices, expanding access to addiction treatment, and spreading the use of naloxone. And over half of California counties are working with us in this effort. Today's lineup, we have Mike Small, who is the director of CURES, who will start this off. Mike has a long history in law enforcement. He's often caught saying, well, when I used to be in drugs or when I used to do organized crime, meaning those he was working in those areas, and now he has been nationally recognized as bringing CURES into the modern era in what's called CURES 2.0. And unlike many states, CURES has incredible capacity to help primary care providers and specialists and emergency room physicians see which patients may be at risk of bad outcomes and to be able to identify them and work with them. So we really thank Mike for his leadership over the last few years, giving us this new opportunity to use this tool in this way. Dr. Roneet Lev started the Prescription Drug Abuse Task Force in San Diego and was the model of a coalition that we at the foundation then modeled our entire program out after. She worked with other people in San Diego to bring hospitals and medical societies and law enforcement and community advocates and everyone together to tackle the opioid epidemic, and they've made incredible progress. And she'll be presenting the point of view of using CURES in the emergency room. She's also the director of operations at Scripps Mercy and is an emergency room physician there. Jessicca Moore is the clinical director of improvement at Petaluma Health Center and has led many of their innovations and quality improvement efforts at this health center, and will be addressing the use of CURES in a busy primary care office. So next slide. A little bit of housekeeping because we anticipate a large audience today. Everybody will be muted. The session will be recorded, so you can go back for future reference. And we will send you the slides and the recording within a week, and it'll be available on our website. We do welcome questions, and the way to use the questions is to use the chat if you have any type of logistical issues, or you can use the question and answer box to get questions about content. And we will ask you to stay on the line and do a brief survey at the end of the webinar. Okay, next. We do welcome questions, and so if you have questions that are not addressed during the course of the webinar, our speakers gave their email address here. And we do want to emphasize that although some people have had trouble with registrations and getting responses from the CURES office in the past, they've got an army of people ready to assist you, and they're fully caught up on email. So any challenges you or others have with CURES registration or a question about CURES after this webinar, feel free to use that program address at cures@doj.california.gov. Okay, I'm going to turn it over to Mike Small. And again, thank you so much for joining us today. I imagine there's a lot going on in CURES a couple days before the deadline, and I know everybody's interested in hearing your perspective. We'll just take a minute to turn the slides over, and there we go.
Good afternoon, everybody. CURES 2.0, which launched back in January, is much like the original CURES program, does store and report on all Schedule 2, 3, and 4 prescription dispensations in the state of California. And we are able to provide a clinical view of a patient activity report of a patient's prescription history of up to 12 months. This allows you to see any potentially contraindicated narcotics that your patient has been prescribed or is being prescribed, or just to see whether your patient perhaps indicates a at risk or potentially addicted and to help you prescribe safely or to intervene safely for that particular individual. We did invoke a analytics engine into the CURES 2.0 build, which allowed us to do entity resolutions every single evening. We get 150,000 prescription records every single night, and we deduplicate those with the existing prescription reports on file. So that way we can provide alert generation capability in addition to the traditional presentation of the prescription history when you're proactively seeking CURES lookup on your patient when you're contemplating narcotic substances to your patient. So these anomalies that we can provide you a reactive view to. Our business analysis in designing CURES 2.0, we recognize that while you may have a good electronic healthcare record of all the medical activity occurring within your own healthcare plan, the EHR still is not universal, and you may not know what a doctor in another healthcare setting is prescribing to your patient. So we thought being able to provide an alert to you when, in combination with other providers that you are unaware of, when you reach certain therapy levels that might be worth noting for potential harm, that we could, our system with this analytic engine can provide those alerts to you and report them back to you. So what we do every evening is we deduplicate and we resolve each patient entity. We then parse out the the current prescriptions based on day supply and date issued, and then we calculate the medicinal values of those aggregate prescriptions. So any patient who is receiving more than 100 morphine milligram equivalents a day, that every morning that statement will send an alert to each prescriber who is actively prescribing for that patient those drugs.
Mike, could you speak up a little bit? Sometimes you fade out.
Okay, I'll pick up my phone. Also the same for if the patient has been seen 6 or more pharmacies, 6 or more doctors in the last 6 months, indicating a high prescription seeking behavior, will provide an alert for that. Also, if the patient is receiving more than 40 milligrams of methadone daily, 40 milligrams equivalent of methadone daily, an alert. Also, if the patient has been on prescribed more than 90 days consecutively of opioids, that will generate an alert. And then also, lastly, if the patient is getting both benzodiazepines and opioids, we'll send alerts. They're informational only. They're only intended to help make you aware of a situation that might have been created by concurrent prescribing by other prescribers you're unaware of, and if they're certainly not meant to question your judgment. If you're the sole prescriber and you've intentionally, in your good medical judgment, made prescriptions in that area, it's just informational only. There's no expectation or requirement that you do anything with those alerts. They're just meant to be of informational value. So in addition to the patient safety alerts messaging I just talked about, we did create for CURES 2.0 an automated registration process. Admittedly, it's not as user-friendly and fluid as I would even like it to be, but I am not the owner of the licensing records for your licensure, so we necessarily had to have a multi-segmented registration process where we can check the license files at Department of Consumer Affairs as well as the Drug Enforcement Administration, and then send back an approval. So it is admittedly multi-step, and there obviously can be some confusion when you involve multi-steps. So we are continuing to work on improving it, and I hope that it works well for you. And if not, I urge you to just give us a call or email us right away, and we'll be glad to help you. We did also provide a delegation authority, and by that I mean as a prescriber or even a dispenser, you can delegate an individual to make the patient activity inquiry requests on your behalf to save you a few steps and time in that task. The responses will come back to you, the clinician's account, but at least that should save you some time and effort in getting those queries launched. We also have compact flagging, and by that I mean, this is usually in the case of addiction medicine treatment, the doctor might insist that the patient exclusively get his or her prescriptions from the treating doctor, and they oftentimes create a contract for that relationship. If you have that sort of relationship with your patient, you can notate that in CURES 2.0. So if that patient does go present himself to another doctor seeking prescriptions, that doctor can be made aware by that virtue of that flag that it might be dangerous to provide him any drugs at all that might be contrary to his treatment with the compacting doctor. Then peer-to-peer communication is an ability to message other prescribers and dispensers that have that same patient in common to make an initial contact, especially across healthcare plans. You can immediately communicate by messaging to these other prescribers about concerns you may have based on either the compact or the alerts. So the CURES 2.0 screen itself is, once you've signed in, this would be the home page, and to launch a query, a patient activity report, you can either select from the pull-down PAR tab up here and select patient activity report, or in this favorite section you can create new activity report. Either place, a simple click navigates you to the request screen, and where you need to enter either a last name or a first name, one or the other is required, and date of birth is required. And you can select a range of months up to 12. You could also make the query by date range. I don't recommend that because that takes a few more steps and a little bit more time. So since you're only access up to 12 months, I recommend you select 1 to 12 months for your search. And then, of course, you'd hit the search button, and the return will be all of the prescription recipient entries by their various variations. Like in this case, you'll notice Las Palmas Drive, and Drive is missing from this address in the second entry. We don't deduplicate patient entities for you on the premise that if the patient's right in front of you, you could probably best decide who your patient actually is or is not. So you can either select all, where this arrow is indicating, or you could select one or many of the individual listings of these patient entities. And once you're comfortable with your selection, you just simply click the View Details, and this result will return immediately, usually no more than 4 or 5 seconds. It's supposed to be 1 to 2 seconds. This result shows you a carousel of the patient entities themselves. So this would be Mike, Michael, Mikey, however many. It scrolls, and then the prescription details themselves down below that carousel here, and this result number, for instance, 3 in this column results to the person entity number 3 here. So that's who's receiving that particular prescription. This activity report can either be downloaded to an Excel spreadsheet for extremely easy review, or you can print it out as a PDF as you've been able to in CURES 1.0 all along. So yeah, either way you can print those out. You can generate a certified report, which is basically a par with a certification information that's good for legal purposes. So registering for CURES 2.0. And as I mentioned before, it is an automated process now. And you can go to our CURES homepage at oag.ca.gov/cures. And on that homepage, you can simply select the CURES registration link. And the first thing you will see is a page asking simply for what role you're registering under, and it's either going to be a prescriber or dispenser. It will be your choices. Also, you're going to indicate whether you're licensed by the California State Department of Consumer Affairs, or whether you have an out-of-state license from some other state, one of the two. And then you provide your email address and re-enter it for so we ensure it's accurate. And then we have the CAPTCHA, of course, that security demands that you enter for make sure this is not a robotic attempt to hack into CURES. Then you hit the submit button, and the response on screen will be this message right here, letting you know that you'll be getting an email. And then simultaneously, you'll get, rather instantaneously, you'll receive an email from CURES that thanks you for providing your email address for a verification, and then asking you to click on this link provided right here to continue the process. So as soon as you click that link, you have the remainder of our registration process, which is you provide your name information and date of birth, either your social security number or your individual tax identification number. Now you want to provide us whatever you provided the Department of Consumer Affairs for the purpose of your licensing application. If you provide the social security number and that's what DCA has on file, that's what you want to provide us. If you provided the ITIN, the individual tax identification number, that's what you want to provide us. Because if you provided the social security number to DCA and you provide us the individual tax identification number, there will not be a match and your application will be denied. So you want to make sure you use the number that you used at DCA, allows us to validate that and approve your application. Then it asks for your licensing board and type, your license number. There you want to put the numerals only. The alphas will reflect your licensing type. For medical doctors, it's AC or G, and then your DEA number, of course. And then we have a number of security questions that please answer and commit those to memory somewhere or on paper for future reference, because you will need those if you ever need to reset your password. And then another CAPTCHA, of course. So you hit the next button, and it brings that information up you just provided for your review. And it provides the terms and conditions of the use of CURES. So you certify that your statements are true and that you understand the terms and conditions, and then you hit the submit button. And within that provides you this confirmation that you submitted your application. It provides your application confirmation number and the information you had provided, so you can print that out if you like. And then you simply close out, and you'll wait 24 to 48 hours while DOJ interacts with the Department of Consumer Affairs and with the Drug Enforcement Administration to validate the license numbers that you have provided us, as well as your identification through your Social Security number. And then we will, when you are approved, you will receive an email from us denoting you're approved, providing you your user identification number. And with that, you will have another link to go to where you provide us your user identification number and answer a couple of security questions, and then we send you your temporary password and another link to the login page itself where you enter both your user ID and your temporary password. It lets you in. It asks you to establish a permanent password for yourself that only you know, not our system. And then it asks you to complete the user profile, which things like updating where you can update your address or email address or add all your DEA numbers and the like. And then you're a CURES user once you've completed that. You are free to access the system at any time, 24 hours a day. And we are at cures@doj.ca.gov if you need any help or assistance, or our phone number 916 area 227-3843. So, Ellie, I'll turn it back.
Mike, that was so great. That was very, very helpful. In the interest of time, I'm going to continue us moving along to Dr. Roneet Lev, and people have been sending me chat questions in the question box. I've been answering them to everybody when it might be of general interest, and we'll hold some of the more specific questions to the end of our Q&A. So, Roneet, please take it away.
Hi, everybody. Thank you very much for this opportunity. I just want to let everybody know that we're very lucky to have Mike Small in his position with CURES. He's a real advocate for physicians and for patients. And thank you, Kelly, for all your organization and the California Healthcare Foundation. So next slide. What I'll be talking about today will cover 5 points. 1, when you should check CURES. 2, what should be your dashboard goals? Mike showed us all the different dashboards that show out in CURES and what should be your goals with that. 3, how do you interpret a report when you look at it? 4, how to document your findings on CURES. And finally, how to talk to patients about findings, or how I call it, how to say no nicely. Next slide. So first thing, when should you check CURES? So ideally, the gold standard would be before you write a prescription that has a potential of killing someone, you would check the CURES system. You would never think about giving someone a prescription for amoxicillin without asking them about allergies. And similarly, before you write that prescription and give it to somebody that has so many implications, over 4,000 Californians lose their lives to prescriptions. Before you take that step, you could take 2 minutes to make sure that that is a safe prescription. Additionally, many people think that CURES is just, it's this doctor shopping website, but that's not the case. I say CURES makes you a better doctor, a better clinician, because it just gives you additional information about your patient. I'll give you some examples. I had a patient that I was admitting to the intensive care unit with DKA, diabetic ketoacidosis. And he was there because he says, well, I just couldn't get insulin. I don't have a doctor. But somehow on his medication list, he says he's getting oxycodone. And it didn't make sense to me. So I ran a CURES report and saw that he was every month seeing a doctor. And when I asked him about it, he goes, oh, that's not my doctor. That's just my pain doctor. So you learn things about your patients. I had a patient just the other day with abdominal pain, and she said she's been having it for some time. She can't figure out what's wrong with it. And I saw within our own script system that she went to one other hospital. And it was a little fishy. I ran a CURES report, and through that I found out that she's been to 5 different hospitals and received prescriptions within 1 month. And that was very important, not just in terms of pain medications, but a young person shouldn't be exposed to lots of CAT scans. And I could talk to her about that. I've been to 5 different hospitals. I don't want to do another CAT scan on you if you already got it somewhere else. That would be unhealthy. I had a patient the other day who was getting booked to jail. And he says, well, I went to another hospital for this the other week, but I don't remember what they gave me. So I ran a CURES report and found out he was getting Librium, and he was probably in alcohol withdrawal. And that was very important because if I'm sending him to jail, I don't want him to get seizures there, and I want him to be able to get that Librium. Again, just something that makes me a better provider, has nothing to do with the opioid epidemic or doctor shopping. Next, we'll talk about, this slide went backwards, so we want to go forward and one more. Okay, the dashboards. The first time I ever logged into CURES, I was shocked that I had 4 patients on my dashboards. I consider myself the queen of CURES. I should have like a clean dashboard, but I didn't. So I would just warn everyone, the first time you look at it, you may be surprised. And some things are legitimate, they should be there, and some of them are a goal for you to have. So these are dashboard goals that I would have. Mike explained that CURES gives you 5 different alerts. So as an emergency physician, my goal is to have no alerts. I should have a clean dashboard. But I realize that not all medical specialists are in that position. So there should be goals for the other alerts. So for example, the first alert is more than 100 morphine equivalents per day. So if you have a patient that are legitimately on more than 100 morphine equivalents per day, they should be getting a prescription for naloxone. This is one of the CDC recommendations that went out this year. So that would be a goal. So if you have a dashboard alert with more than 100 morphine equivalents, make sure those patients have naloxone. The next alert is the 666 combination. 6 providers, 6 pharmacies within 6 months. That person's a clear doctor shopper, and then you have a challenge with that, and probably not to prescribe, not to get that one off your dashboard, and get that person help with addiction. More than 50 equivalents for methadone, that would be someone who warrants a prescription for naloxone. Greater than 90 days of opioids, that one is a very important alert, and I think our medical examiner study was influential in getting this alert on the dashboard, because we found that 78% of all people who died met that criteria of being on the same exact medication for 90 days or more. So if you have someone like that on your dashboard that's your patient, they should have a compact. You should click that and let other providers know that this is coordinated care. If you're not the provider, then you shouldn't be giving that person prescription. If that is your patient, you should be alerting other providers that that person has a compact with you. And then the final one, opioid and benzodiazepine combination, that was important too, because our medical examiner data showed that 50% of all people who died received that combination, and 20% of people, the cause of death was that combination. So that is a drug interaction that needs to be avoided. Our VA hospital in San Diego did an outstanding project in minimizing and creating alerts to prevent that combination. Next slide. And now, how do we interpret a CURES report? So you'll see different things on a CURES report that could be very helpful, again, not just for doctor shopping. When I run a report, I always run it for 12 months because I want a total picture of the patient. And I usually click on print report instead of Excel file because it's just easier to see and to print and put in the medical records. And if this is an example of a mocked chart, I could see right away that this person has received what we call the unholy trinity of soma, opioid, and benzodiazepine. So that's kind of a red flag of a dangerous combination. There's a dangerous combination here of opioids and benzodiazepines that I would want to discuss with my patients and tell them that they need to see their doctor about that, not to take them together. I see under doctors multiple providers within a short period of time, and that's also a red flag. By looking at the pharmacies, I find that, hey, a few months ago, this patient was actually a Kaiser patient, and their insurance probably changed. And, hey, at one point, they were getting buprenorphine. So someone at Kaiser, before their insurance changed, and they have records that I can't see, but somebody thought that they had an addiction problem. And they actually were off medicines for several periods and then started getting them again. So I've learned a lot about the patient's medical history from this report. Next slide. So what should you document? Mike will tell you that the intent for CURES is to be used as a HIPAA-related medical document. So you can print it, the PAR, put a patient sticker on it, and put it in your medical records so you could share that information within the regulations of HIPAA. Similar to having a cancer pathology report, you wouldn't want to hide that from other providers. You need to share that information so we could do the right thing while they're in the hospital, while they're in the clinic. So it's HIPAA protected information, but it should be used in that sense. And your institution should think about where should we file this within the electronic health records so other people can see it as well. In your own medical dictation, so I dictate my records, and after I record the patient's medications, the patient is taking, simvastatin and carvedilol and Vicodin, whatever else. That's what the patient told me. Right after that, I can add another line, and I'll say CURES report was negative, or CURES report was 5 pages with 20 providers. CURES report showed regular monthly opioids by a single physician, or something specific like the last prescription was for 60-hydrocodone in January. If the system is down, I have to realize that now that this law is passed, that all providers must have registration for CURES. DEA knows that, medical board knows that. If there's an occurrence, the first question they're going to ask providers are, why didn't you check CURES? And so you need to explain why you didn't check. And you may have legitimate reasons, like the system is down, or it's not available, or my account is locked, and I would say that you need to document that in your record in the same location if that's a problem. And I've also seen physicians help out their pharmacist colleagues with CURES reports by writing right on the prescription that CURES is negative, and that kind of helps the pharmacist along in their responsibilities and looking at CURES. Next slide. And finally, how do you talk to patients? So I've written several talking points and scripting of how to talk to patients about safe prescribing. I have those located on a couple of different websites. But I'm going to share a few examples with you. One is when the patients ask you directly, can I have something for pain? And the answer should always be yes. I learned that from having preschool children, right? You always say yes, and then you kind of, yes, you can have your cookie, but after you finish your dinner. So yes, you can. And let me check what is the best option for you. And then you have time to go look at CURES, look at their records, and find out what is the best treatment for their pain. We see a lot of patients with the benzodiazepine and opioid combination, and I get that information just by taking a medical history. And I will say, hey, I see you have a medication interaction. It's easy. My job is easier as an emergency physician because I say, you need to discuss this with your physician, but in the meantime, please don't take them at the same time. And the primary care physician now has to deal with the issue of weaning and combination. Next slide. Another example is, what do you do with the doctor shopper? First of all, we have to realize that doctor shopper is a research definition or a definition in the CURES account, that 666 number, but it's not the gold standard. The gold standard for prescribing one doctor and one pharmacy. So that is the gold standard, and that's the one that we are promoting in the House of Medicine. So if somebody needs to be on medications chronically, it should be coordinated by one doctor, one pharmacist. Now, if you find that that's not the case, and I'm using the definition Dr. Shopper just to say that this is not with the gold standard, you could say, you know, for your safety, your medications need to be coordinated by one doctor and one pharmacy, and I can treat your pain today, but it's for your safety. I cannot give you prescriptions. A common one I hear is that nothing works for me. Patients say, well, nothing else works for me. I need X, Y, Z. And the answer is, please tell me, how are you taking your medications? And you'll be surprised how much just that question can help you out a lot. Because you'll think, okay, this guy's just asking for drugs for me. But if you ask them, how are you taking your medicines, you'll find out, well, I took one Motrin, you know, over 24 hours ago. Well, that's you know, we could work with that. We need to can increase. Tylenol and Motrin for an opioid naive person works better than Vicodin. So you can learn a lot from that. If you have patients with high morphine equivalents, I mentioned this on the dashboard, you should be giving them a prescription for naloxone. But I talk to patients and tell them a couple of things. I said, I'm concerned about you because you have two things. You have your headaches that you're worried about, but you also have a problem with prescriptions. And there are studies that have shown that people with chronic pain like you actually function better when they're taking less medicines. It doesn't mean that they have less pain, but their overall life quality is better if they're taking less medications than the whole bunch like you've been taking. And you've been using these for all these years and you're still needing more. That's not a good position. We need to reassess things. Next slide. And a few more ideas. Get a lot of excuses. I can't get to my doctor. If you hear that, you could run the CURES report and you could see whether they've seen a doctor or not. One thing that I've learned from my pain specialist colleagues is that when they see a first-time patient, the first thing that they do is an evaluation. They run the CURES report, they get medical records, they get a urine drug screen. The first thing they do is not write a prescription based on the word of their patient. If their patient says, oh yeah, I need 8 oxycodone a day, they don't say, okay, here's a prescription for 2 weeks of 8 oxycodone a day, come back in 2 weeks and we'll figure it out. They say, no, we're going to do an assessment first and not give you these medicines you're asking for and then come up with a conclusion. So if my pain specialist colleagues do that, then as an emergency physician and a primary care doctor, you could have patients wait as well to make sure you're doing the right thing. It would be horrible to have them give a prescription while you're doing your assessment and then they don't live or die from your prescription. And I think about that every time I write a prescription and why I write the CURES report, because the worst thing you could do is have your name on a prescription that ends up at the medical examiner's office. And in 1 year in San Diego, that happened to 713 doctors. So that happens a lot without you knowing it. A common one is of patients who are asking for cough medicines with codeine. They'll say, doctor, can I have something for my cough? And I say, yes, I'd be happy to. I'll give you an inhaler, something that opens up your lungs and gets the junk out. I don't want to give you a cough medicine that keeps all that crud inside you. Another one, stolen prescriptions. Prescriptions are federally controlled, issued. If that happens, you need to file a police report. Did you file a police report? And then a lot of times, oh, never mind. Next slide. So here's some resources. I have a lot more scripting if that is of interest on the California ACEP website. Under Improving Health, you could look under Safe Prescribing, and I call it How to Say No Nicely. Here it's called How to Communicate Safe Prescribing Guidelines to Patients. And next slide. And we also have our San Diego safeprescribing.org website with a lot of information. If you look under educational materials for patients, you could find it under How to Talk to patients about safe prescribing. We have a lot of other of our guidelines in there as well. And finally, we're really promoting in the medical community one vision for safe prescribing. It doesn't matter whether you're an emergency physician, a pharmacist, psychiatrist, dentist, primary care doctor, surgeon, pain specialist, and we are adding health plans. So regardless, the gold standard is one provider, one pharmacist for any chronic prescription, using CURES like you would for checking allergies, using medication agreements. And the CURES, it's called compact. That's not a common word for a lot of us, but in the CURES system, it means the same thing, compact, using those for anybody with a chronic prescription, not mixing, avoiding opioid and benzodiazepine, and honoring the emergency department guidelines that state that the emergency department is not the place to get new prescriptions. And that is what I have. Thank you.
Dr. Lev, thank you so much. You've just shown such great leadership in San Diego and across the state for how the emergency department can really contribute to reversing this epidemic. For participants, you'll notice that there's several questions that have come in, and when they're of general interest, I forwarded the answer to everybody. So in your question box, you can see some good information. Especially had some recommendations for Kaiser docs to check CURES, and sometimes people in Kaiser don't realize that you can go out of the system, pay cash, and that won't show up in the Kaiser record. And that dentists also should be checking CURES, as dental pain can be a way for people with addiction to get access to medications that ultimately do them harm. So now I want to turn them over to Jessicca Moore. And Jessica, one question that came up was how the use of a delegate can work in a team model. So hopefully you might be able to bring that up in your presentation. So Jessicca, thank you.
Thanks, Kelly. So how to use CURES in primary care. So Kelly's question about the delegate, really coordinating the use of CURES in primary care is what we found to be the key. And in our practice, we start that with our huddle. So before the morning or afternoon clinic shift, our team gets together, we review all of the patients on the schedule for that day, and for any patients that are coming in who we know are getting pain medications, either from us or another physician, or if there's something in the chief complaint, or if we've got something from the ER that makes us suspicious just from the beginning, we go ahead and let our medical records staff know, hey, I need to a CURES report for this patient. And so they'll go in and log into the system and get that ready so that it's ready for us at the time of the patient comes in. So when you're thinking about how to set this up in your practice, it's important to think about, okay, who is on your team? What does your team look like? And how can you make some sort of a coordinated model work in your system? We've also done a lot of work in our EHR using the system that we have so that it's clear when we need a CURES report and there's a consistent place of documenting it. So the last question, just how can you use these systems to really work together to the full potential of your team? So this is just a screenshot of what our alerts look like. So when we're huddling on a patient in the morning, this is what we're seeing. So you can see that there's circled there the patient activity report. So we have an automatic alert set up for anyone with a chronic pain diagnosis on their chart that at least once a year we're getting a patient activity report. There's a couple ways that we can order that in the chart. So if we didn't notice it at the huddle, or we've decided that we want one, and maybe it hasn't been a year, but there's some suspicious history, or I'm a little concerned, I want to just go ahead and order one at the time of the visit. So this is our order set for chronic pain, and so we're ordering a patient activity report, which triggers the delegate to get that report for us. We've also incorporated a lot of this information into our standard template. So anyone with chronic pain who's coming in we're asking the same questions in the HPI so that we're getting a complete history from these patients. So the results are in, and what does it look like? So this is actually a report from one of my patients who I was not prescribing these medications for the patient. She was seeing neurology, but this is what came back on her report. And you can see in the highlighted areas here, what came back was essentially a 90-day supply of hydrocodone within a 35-day period. So I felt like we needed to have a conversation. And this is her story. So this is a 26-year-old female with a history of chronic migraine and seizure disorder. She had been seeing her neurologist, who had been prescribing her hydrocodone 1 tablet TID and clonazepam 1 tablet TID. And interestingly, I hadn't seen any notes from neurology in over a year for this patient. So when I got that report, I was concerned. So the reason I ran the report was she had recently sustained a clavicular fracture and was having acute pain. So this is where it gets difficult, right? So what do I say? Now I have this information, that's really useful information. I want to give the best care to this patient, and what do I say to her? So I'm really transparent with this. You know, I want to show you something. And I actually, you know, turn the screen around and have her look at the report with me. You know, it looks like you're using more medication than prescribed, and I'm concerned. So then I give her an opportunity. Tell me what's going on here. Maybe there's something I'm not seeing, but based on this information, I'm really concerned. And I want to help. I think that Dr. Lev's, point about saying yes and is, I'm not trying to cut you off. I'm not trying to hurt you. I really want to help. And we have to work together if we're really going to take the best care of you. And then realizing that, if this patient is suffering from addiction, it is a chronic condition characterized by relapse, and we just need to be open with that. I recently did a CME through Stanford that was really useful in just helping the clinician to kind of recognize what these kind of conversations and these difficulties with patients, what it brings up for the clinician. So, often in primary care, when you have someone who is, asking for more medication, you feel anxious. When you find out something, that someone's been taking advantage of you or another colleague, you even feel angry, frustrated, and guilty sometimes. Why didn't I see this sooner? Something about this is my fault. And then kind of sad and overwhelmed. It can feel all of those things sometimes. So that's the gist of what I wanted to get across today for primary care. I'm happy to talk about how our team works, but I know that we also wanted to have plenty of time for questions for all of the panelists today.
Thank you so much, Jessicca. I mean, one of the things I really want to call out from what we heard from both Roneet and Jessicca is this need for what Camden Coalition is calling unconditional positive regard, and they're actually teaching their coaches who work with people with addiction to practice this tone with patients of unconditional positive regard, because we've learned the hard way that the disapproving, judgmental tone that sometimes we take adds to stigma, makes it harder for patients to take action to improve their lives, adds to their own sense of self-hatred. But the ability to have a neutral approach, to share the data, to share concern, and then identify this behavior not as a sign of a bad character, but as a symptom, because the symptoms of addiction are using multiple doctors and pharmacies and nurse practitioners and dentists for opioids, just like the symptom of uncontrolled diabetes is high sugars. And the more we start treating anyone with a chronic disease compassionately, the better we'll get. So we had one question about specifically the use of delegate, and maybe Mike, can you answer what the delegate function can and can't do? For example, the delegate can order something but can't print it up. Can you clarify that for us?
Absolutely. Yes. My attorneys, all 1,700 of them, basically held to the point that that sometimes the delegates are not really truly licensed professionals, and therefore, while they can launch a query on behalf of the clinician, that only the clinician, the licensed professional, should see the results because it is HIPAA information. I realize that's not exactly how it works in the real world setting, but I'm legally bound by what my attorneys allow me to do or not to do. So the result is the delegate is allowed to launch the response to that query will come back to you, the account holder, the professional, to see those results.
And there was also a question about who has access to this data, and this question comes up frequently. So Mike, could you address if a health plan wants to find out who their high prescribers are, and a hospital wants to find out who is registered for CURES and not registered for CURES, is that data available?
No, it is not. Again, the legal interpretation on this is that it's an individual responsibility on the licensee's part to register for CURES, and it's not a matter of revealing that information about whether you've registered or not, or complied with the law or not, to anyone but yourself as the individual registrant.
And just to confirm, when a delegate can get a separate registration and login, correct? But the delegate won't be able to see the report. Like an MA who logs in can send that report to a prescriber so they see that the next time they log in, but that delegate themselves can't have access to that confidential information.
That's correct. The information will not return to the delegate. The information will go to the prescriber or dispenser whom that delegate has been authorized to make those queries on their behalf. Any individual clinician can have X number of delegates, and any delegate can be a delegate for X number of clinicians. So it's very easily managed on a one relationship by the clinician going to his own account and select manage delegates from the selection screen on the top, the selection bar on the top, and it's simply a matter of entering the person's name and email address and accepting the terms and conditions for that person's behavior.
We had a question about how do you get more information about this concept of unconditional positive regard, because in the pharmacy world, a lot of pharmacists see themselves as policemen, and there's a kind of a balance between pharmacists taking up their corresponding responsibility to work on addiction, but at the same time not contributing to stigma. We at CHCF commissioned a 1-hour virtual CME program for pharmacists that should be available within the next several months. So we will make sure that everybody on this webinar gets announcements when new CHCF opportunities come out. Also, Camden Health will be shortly publishing a website that Corey Waller developed, which is full of training materials that will include this concept of how you coach people in unconditional positive regard. So again, as soon as that website with all those short videos and training materials is available, we'll make sure that everybody on this list gets that. We also got a question about the Stanford resource, so I will be putting that in the chat box to make sure that everybody has access to that. And so Mike, one question came in, why can't the default for CURES be 12 months? Because everybody seems to have to manually put in 12 months, and that's the best practice. Is that something that can be changed?
It could be. We selected 6 as a default because just based on use of the system, it seems like most clinicians ask for either a 3 or a 6 month So we made it 6 just to be as accommodating as the statistics indicated. However, we'd be more than happy if you think a 12-month default is the ideal. We'd certainly entertain that as long as we don't get too much complaints, from others about that.
We had a question about, is there a restriction in giving a medication refill or prescribing controlled substances if it hasn't been 30 days? I think the answer is it's within the prescriber's judgment, although some insurance companies may not approve early refills. Any comments from Roneet or Jessicca on that question about refilling before 30 days?
There's no FDA restrictions on that, and the hundreds of CURES reports will show you that because you see that that's happening all the time. So
it's more of a plan restriction often than anything.
We had a question about CME and education credits. Unfortunately, CHCF has not yet built in the infrastructure for some of these webinars to have CME, but we will certainly work on that for the future. But we don't have formal CME for this again. We got a request to go back to the slide that says, what can I say, from Jessica's presentation. So Jessicca, if you could go back to that slide so that people can see it. There was a question about, can you tell me more about the grace period about refill medications 5 days prior to the refill date? Does anyone want to address that?
About the grace period 5 days before the refill date?
I think what this means is that some health insurance companies will allow early refills as much as 5 days early because they don't want to build in difficulty if for some reason someone's going on vacation. So I think that grace period varies insurance company by insurance company. And some insurance companies are starting to tighten that up so that you can't refill, or they certainly won't pay for refills sooner than 30 days. Any comment on that? From any of the from me or Jessicca?
I think the thing that I'm always looking at is not necessarily when I'm looking at a CURES report or when I'm thinking about refilling is not always the exact day, but okay, especially if this is someone who's getting chronic medications over time, like are they getting earlier and earlier, or are we on average they're getting their 30 days for the 30-day supply and it's lasting 30 days? I don't know if that exactly answers your question, but.
That's great. We got a couple questions about alerts, and do any alerts go to provider's email? And Mike has clarified in the past that that because of requests from physicians about getting spammed, there's no alert or communication between providers and CURES that goes to an email. Every provider needs to log into CURES to see a report run by a delegate, or to see a communication from another provider, or to see an alert. All of those things are only visible once you log into CURES. Robert, could you go to the slide that shows upcoming events for CHCF, as I will want to highlight those before we close. And, so one question is, are prescribers of psychotropic medicines for children under 12, do they need to use the CURES system? And I'm just going to answer this quickly, that every prescriber must register for CURES system, but currently there's no mandate to check CURES, although certainly that is in place in other states and has been advocated by certain advocates in California. But right now there's no mandate to check CURES, although certainly it's a best practice if you're going to be prescribing controlled substances. There were some questions we couldn't get to today, so I will do my best to print those up and respond individually to make sure that there were no unanswered questions, but we'll need to close the webinar within a minute or two. So I do want to highlight some upcoming events. One is that we've got a great presentation on July 12th from Dr. Corey Waller, who's nationally known for being an addiction specialist, a pain specialist, and a leader on thinking around complex care. He's going to be joining Jeff Brenner's shop at Camden Health, who was famous for hotspotting New York article. he does a brilliant lecture on what neurobiology teaches us about the impact of long-term opioids on the brain. Sounds so boring, but I tell you, there's no one who can make brain chemistry sexier than Corey Waller. On July 27th, this is specifically for those who are working in coalitions. There's a webinar on how to spread the word. You don't have to be part of a coalition to attend, but this is tailored at those who are trying to work in local coalitions to understand how to get word out to community. And we've got a great presentation August 10th on how to use the model Get to Zero Suicide, which has been successful in driving suicide deaths to zero, and some large mental health systems that have adopted the model. We're talking about how that model could be adapted to overdose, so that if a system decides they want to have zero overdoses, how you actually can get there through engaging leadership, managing transitions, engaging patients, identifying high-risk patients, and things like that. And finally, we'll be publishing invites to this in the future, but for all of our coalitions across California, we're offering convenings with the exact same content in the north and the south to minimize travel costs. So September 22nd at Oakland Airport Hilton, we'll have a full-day session with we will then be having remote live video feeds to Redding, Dunsmuir, Santa Rosa, and Fairfield, not in Eureka. That has actually been changed. We will have a similar session November 1st in Newport Beach, and just great nationally known speakers. So our webinars end. Again, thank you so much to our speakers, Mike Small, Roneet Lev, Jessicca Moore, fabulous presentations, and exactly what I think busy prescribers need to see in terms of how to use these systems. And then if you have any questions that were not answered, I'll work on answering them, or you can email our speakers or myself directly. Have a great day.